Welcome back to our session at the University of Maine Homeland Security Lab. As we get into the late morning speakers, we are going to see a significant change in direction, and we are going to look at the issue of healthcare workers. We're going to deal with real-world situations, not hypothetical threats, and at the same time talk about vulnerable populations in just a moment. But we have with us now from Toronto, I must say, one of the foremost experts in her field in terms of looking at the impact of prolonged healthcare support operations on healthcare personnel. Dr. Rima Styra is an assistant professor in the Department of Psychiatry at the University of Toronto. She is the director of continuing medical education for the University Health Network Department of Psychiatry, and she is part of the broad Toronto healthcare community which coped with and dealt with quite successfully the recent outbreak of SARS. She's done extensive research on the quality of life in patients, on quarantine issues. In addition, she has a study out which looks at the psychological effects on healthcare workers working in high-risk areas of a major Toronto teaching hospital during the SARS outbreak. And so it is a great pleasure that we now invite Dr. Styra to participate. Dr. Styra, welcome.
Thank you. What I'm going to do today is basically talk about some of the issues that we learned from our experience in SARS. My objectives are to actually review the different aspects of the SARS outbreak and how it affected people who were quarantined, people who were healthcare workers, or actually people who became infected with SARS. And I'm going to focus on the psychological implications of such a traumatic event on those affected directly or indirectly. And these would be the patients, again, the healthcare workers, and the community at large. We in Toronto ended up having 251 cases of SARS. We were the fourth largest center during the outbreak in terms of the number of cases that we had, and we actually had 44 deaths. What I want to do is actually clarify for you the whole issue of isolation versus quarantine. What I want to tell you is that it's really important to understand that isolation is really, we're talking about the patient who's ill, the patient who's been infected with the disease, and usually they're in hospital. And it's usually only the individual who's basically isolated. And yet when we talk about quarantine, we're talking about people who are well, who've actually had an exposure to the disease. But usually the quarantine takes place at home, or in some of the Toronto hospitals, we had people who actually were healthcare workers who were going to work during the day because of the manpower issues, and then were in quarantine when they went home at night. And this tends to involve usually individuals, family members, or groups, as in this case, hospital workers in specific hospitals that had SARS patients and exposures to them that were not protected. What I'm going to talk about, first of all, are actually the patients who were diagnosed with SARS. What you need to understand is that when these individuals were placed in isolation, they had no visitors. They were in a room by themselves. They had healthcare workers who came in and wore protective equipment, so they were wearing gloves, gowns, masks, goggles. The time that the staff spent in the room was actually limited, and that was for the protection of the staff. So people saw staff very infrequently, and there was a variability of resources that were provided to the patients. For example, there were many patients who ended up not having a television set or many other resources because there was a fear of technicians or other personnel going into the room and hooking up these resources. So what we thought and what we saw clinically was that by far this was a very traumatic type of event for these individuals. So we started thinking about PTSD, and what we know about PTSD is that it occurs with specific types of illnesses. And we've had rates that have been reported for women with HIV, individuals who've suffered cerebral aneurysms or strokes. what's most interesting is actually follow some work that's been done by Dory Reisman out of the CDC that was actually just published in JAMA in April of this year. And what she looked at was anthrax infection and health outcomes at 1 year. And these were the survivors of anthrax in the U.S. Postal Service. What she found that even 1 year later, they continued to have psychological distress, symptoms of depression, anxiety, OCD, and hostility. And probably that relates to anger. They also had significantly reduced health-related quality of life. And at that time, she actually speculated that PTSD might actually be the mediator of this particular distress. We also know from the literature, in looking at an outbreak of Legionnaire's disease in the Netherlands, that a number of people, 15%, continue to have post-traumatic stress disorder symptoms 17 months after the diagnosis. So what we decided to do in terms of the groups that we looked at was look at the psychological impact, and we were going to use 2 scales. One was the impact of event scale, which was going to determine PTSD symptomatology, and the other was the Center for Epidemiological Studies Depression Scale, the CESD scale, which has been widely used. Before we go on, I actually just want to let you know a little bit about DSM-4 criteria for post-traumatic stress disorder. It has to be exposure to a traumatic event, and you have to respond to it because you fear that something's going to happen to harm you, that you are actually at risk of death or serious injury. And for the people who were facing SARS in Toronto, this was a life-threatening event. For the people who actually were patients who became diagnosed with SARS, they only not had the situation of having a new emerging pathogen that nobody knew how to treat, didn't know what medication to use, but they also faced the prospect that their families had been identified now as having been exposed to this pathogen. And when these people thought about their family members, be it husband, wife, children, elderly parents that might end up getting SARS, this was extremely traumatic for them. What we know is that there are a number of symptoms that develop with PTSD, and PTSD develops about 30 days after the traumatic event. They have persistent re-experiencing, so they remember the event. They might have dreams about it. They feel like the event's occurring again. And probably the best example is probably the flashbacks that people had suffered who have been in the Vietnam War. The other one is avoidance and numbing. People avoid anything that reminds them of the actual situation where they became infected or became ill. So you can understand that for healthcare workers, who were the majority of people who ended up getting SARS in Toronto, the hospital would actually be a triggering factor. And added to this, they were actually treated within the same hospital systems where they usually got SARS. The third symptom cluster involves outbursts of anger, difficulty sleeping, difficulty concentrating, and hypervigilance. So they're always monitoring their environment. They're always looking around. They're always concerned what might actually happen to them next. And what it also has to cause, it has to cause some impairment, either in their social function, occupational function, or other important aspects that they're involved in. So what we set out to do, and this is actually, what I'm giving you is an overview of a few of the things that we've done, and probably the most recent material that we have is still not yet available. What we did was, in terms of our patients, we took patients who were followed up in a clinic of 2 teaching hospitals, and we recruited them about 4 to 8 weeks post-diagnosis. We had 33 patients, 11 of whom were non-healthcare workers, 22 of whom were healthcare workers. These patients were admitted in March, April, and May, but the majority of patients, about 95%, were actually admitted in March and April, very early on in the outbreak. And they were assessed within 1 month, basically, so between 4 to 8 weeks of diagnosis. And what we found when you look at these pie charts, when we look at the values of PTSD symptomatology, and we're not saying that we're diagnosing PTSD here, we're just talking about symptoms that they exhibited within specific symptoms of PTSD, symptoms of depression, what we see is that the percentages are fairly high in this patient population. We're talking about 58% PTSD symptomatology, 61% depressive symptomatology, and when you look at those who have both symptoms, we're talking about 48%. And the reason why it's important for us to consider both symptomatologies is that we know from the literature that the prognosis is a lot worse when people exhibit both symptoms. We also looked at their quality of life, and this is the medical outcome study, SF36 scores, and what you can see in looking at the various domains from physical function to mental health is that they are all below the norm of 50. So all domains were actually affected by having had this diagnosis and by the fact that this continued on after hospitalization was really the concerning factor for us. So just to sort of sum up a little bit about our patients, we know that we need to follow, and we are following a larger group of patients, which is going to provide us with further data in this area. And we know that the distress that they experience is longer term. This is not like an influenza, which is cured and people go on and leave hospital and return back to their lives. There are long-lasting effects in terms of functioning and psychological effects. The other thing that we looked at was our SARS outbreak was quarantine. And what we know from Health Canada is that about 15,000 people who were exposed to SARS ended up in voluntary quarantine in Toronto. Many of these people were actually healthcare workers. Some were individuals who were the general public, who actually in many ways didn't know what their exposure had been to SARS, but they had either been visiting or undergoing treatment in specific health care facilities that had identified unprotected contact with SARS patients. And some of these people were relatives of people who were young. And I think for us, this picture kind of sums it up. Basically, it was an illness that people had to deal with very much on their own. They were alone in trying to handle many of the manifestations. And for us in Toronto, it was a very much a mystery illness when we started off trying to tackle this disorder. What we actually did in terms of looking at quarantine because of issues of confidentiality, we actually did a survey. We put the survey up on the net. We announced it through media and via posters in healthcare institutions, libraries, various other places. And we had 152 multiple choice questions. We wanted to look at the knowledge of these individuals and the understanding that they had of the reason why they were in quarantine. We wanted to see whether they adhered to infection control directives and how they had gotten this information. And we also had a large number of open-ended questions. We're not going to be able to cover all of the topics, but we'll cover a few aspects of it. The people who responded were 129 individuals. 90% of them had been quarantined once. 10% ended up being quarantined twice. The median quarantine period was 10 days, which was actually the recommended time period for people to be in quarantine if they'd had exposure to SARS. And greater than 50% of our respondents were healthcare workers. Where did they get their information? Well, because most of them were actually healthcare workers, they actually got their information from their workplace. And the second highest resource was the media. And the media included by far television as the main source, newspapers as second sources. We found that in actual fact, very few found out from public health, only 9%, and from their own physician or healthcare provider, 7%. When we looked at the demographics of these individuals, we found that 64% were within a 26 to 45 year age range. 58% were married, and what was really interesting for us was that 72% had a college degree or higher, so a highly educated, fairly young population group that had ended up in quarantine. What was interesting for us was the fact that even though this was a highly educated group, many of them were also healthcare workers. 15% of those individuals did not believe there was a need for them to go into quarantine. And if you're looking at planning longer term, I think this is a really important variable to consider, that 15% is actually a large number of individuals who did not feel that they should be in quarantine, although they stated at this particular time that they did adhere to the quarantine directives. When we looked at the psychological impact of quarantine, as you can see again, we had a fair amount of distress. 29% talked about symptoms of post-traumatic stress, and 31% talked about symptoms of depression. What we were able to find from our study was that the increased distress actually occurred in lower socioeconomic status groups. We also looked at how people responded to individuals that had been in quarantine, because one of the major things that we had thought about was the fact that we had heard a lot about stigmatization, and a lot of people had actually talked about being stigmatized because they were healthcare workers. And when you look at this particular graph, you can see that about half the people said that people reacted differently to them after they had been in quarantine. Some of the things that they talked about was the fact that people didn't call them, people weren't inviting them to events, and they weren't inviting family members. By far, the majority felt that others were actually avoiding them. The thing that was most distressing for most people was the fact that not only were they stigmatizing the individual who had been in quarantine, but this also extended to their family members. And when we actually looked at adherence to infection control measures, what we found is that we actually didn't do as well as we had originally thought. When we looked at people having to wear a mask in the presence of other household members, only about 82 to 83% of individuals had actually complied. Talking about remaining inside the residence for the period of the duration of the quarantine, less than 60% actually complied in those directions. Temperature monitoring was a really important aspect of trying to determine symptoms and when people should actually go to hospital, because one of the most important aspects of SARS was an elevated temperature. And when we looked at people monitoring their temperature, we were surprised to actually find that about 25% were monitoring their temperature less frequently than was recommended. So that's about 1 in 4 individuals in quarantine were actually not monitoring their temperature for symptomatology. And we found about 7% of these individuals admitted to the fact that they did not monitor their temperature at all. What was interesting for us was that the amount of distress in some individuals meant that they complied with the measures more. With some of the individuals, it meant that they actually complied with the measures less. So we know that distress is present in people who are quarantined. We also know that it has a potential effect in adherence in either a negative or a positive direction. We then are going to go on to our third and last group that we looked at, which was our healthcare workers who actually worked within the hospital systems taking care of patients with SARS, or actually just working in the healthcare facility where there were patients who were diagnosed with SARS. We had about 40% of individuals in Toronto who were healthcare workers who were actually affected with SARS. So for the people working within the hospital system, they were very much aware that their colleagues had been affected by this particular illness. 2/3 of these patients, this is from a study done by Nickel that was published in the CMAJ, reported that they had SARS-related concerns of their own or their family's health. So they were worried what was going to happen. And when they used the General Health Questionnaire, they found that about 29% scored in an area where you would consider psychological distress. But when they looked at nursing staff, that was greater than 45%. So a higher rate in our nursing staff. And this might have to do with various aspects of the job that they were having to do, which might have had aspects of control related to it. The other factors that we know were affecting the increased level of concern were the perception of greater risk of death from SARS. The more you thought that you were at risk, the higher your level of concern, which makes sense. If you have children in your home, you were much more concerned. If there was something that had happened in terms of affecting your personal family lifestyle, and whether you felt you were being treated differently by people because of working in the hospital environment. What we know basically about emotional distress that was found from Nichols' study was that being a nurse, higher levels of distress. If you were in part-time employment, higher levels of distress. And some of that was actually tied into benefits. The other aspect was lifestyle, again, affected by SARS, and the ability to do one's job. So nursing staff talked about the fact that when they tried to do their work in taking care of patients, and everyone within the hospital system had to do this, which was glove, gown, and wear goggles, it was more difficult because every time you went from room to room, you were having to put on the personal protective equipment. This actually interfered in terms of the amount of time that you could spend with patients and the flexibility of you being able to get in and out of rooms quickly. So we actually decided to look at prevalence and risk of PTSD symptomatology in healthcare workers in a major teaching hospital here in Toronto who were taking care of SARS. We used a survey instrument, which was a 91-item self-administered questionnaire. We had 7 domains that presented possible risk factors for psychological distress, and we used the impact of event scale revised to actually look at PTSD symptomatology. The areas that we looked at were the perception of their risk to themselves, the perception of their risk to others. Did they have confidence in our infection control measures? You have to understand that here, when we started out treating SARS, we actually did not believe that goggles were necessary. After we had a spill in our emergency departments, we then instituted different policies for infection control measures. Whether they had confidence in the information that they were receiving. What was the impact on their personal life? When we talk about impact here, people were actually talking about the fact that when they were returning home from the healthcare facilities, they could not interact with their kids. They felt fatigued, they felt overwhelmed, they felt anxious, they felt worried. What was the impact on their work life? Again, the issue that I talked about, the gowns, the gloving. And then how depressing was this whole aspect? And the depressive affect that resulted from it. When we looked at PTSD symptomatology, and again we're talking about symptomatology, not diagnosis per se, 43% had some symptoms of PTSD. The factors that we were able to associate with these PTSD symptomatologies were perception of their risk to others, confidence in information. And what we found was not significant was actually confidence in the infection control measures. So they actually had a fair amount of confidence in that particular aspect, and it did not in any way relate to distress. Again, impact on personal life, work life, and depressive affect were important. What was really interesting and of major significance is the fact that when you looked at the avoidance subscale, and so what we're talking about here is healthcare workers avoiding things that might trigger some memory of the things that they're really concerned about, which is getting infected, which is the health of their patients, the health of their family members. And avoidance means that you try to avoid those particular places. And during a crisis, we all need our healthcare workers to be at their jobs. What we found was that the impact on personal life and the impact on work life were actually factors that affected the avoidance variables as well as the depressive affect. So what we feel is it's very important for us to realize that distress does occur amongst these individuals. We need to actually attempt to address these concerns by education and communication. And we need to realize that there would be implications of not addressing these concerns, especially if there were an event where individuals were terrified in terms of the effects that it would have if they were within the healthcare environment and at that point developed symptomatology that they could handle this distress by actually avoiding the place of concern. So in conclusion, I've given you a little bit of an overview of some of the aspects that we found in these three various groups. It's actually just a bit of information. It's a smithering of all of the variables that we've looked at, and there's lots more data that we have around these issues that we hope we will be publishing and presenting in the future. So what we've been able to do is actually quantify the distress as was determined by PTSD symptoms. And we did that because it was based on our own clinical experiences in dealing with patients, healthcare workers, and individuals who were in quarantine, that we found that this was the area that seemed to be most effective. We found that there was real variability in the levels of distress, and this was often related to how people perceived the threat, and that had to do more with personal characteristics. We also know that managing the psychological distress will probably be the determining factor in successfully managing a biological threat. People who are distressed are not as effective, and these people might not be as able to cooperate with some of the directives or some of the things that need to be done. And we know that the system can only be as effective as each individual who makes up the system. Even though people might focus on the good for society, we need to address and make sure that our individuals who are involved in the crisis, who are having to respond to the crisis, are being able to manage their own distress and therefore help with the situation. Thank you. Are there any questions? I can't hear you. I'm actually going to go and get the person to come. Okay.
Just so we understand, if we talk about interoperability, we talk about multi-agency response. We have this model at the back end where the people you're dealing with, the patients, those who have been infected, are probably going to have some degree of compliance, etc. And I think it's very important what Dr. Stiver is bringing into the mix here is this understanding that the healthcare workers, that critical group that has to be everyone.
Okay, I can hear you now. I wasn't able to hear you before.
Yes. Dr. Stiver, we do have several questions for you. Can you hear us okay now?
Yes, I can.
Go ahead, George.
What can you do to help people recover from post-traumatic stress?
Post-traumatic stress is actually, there's two different types of treatment basically that are involved in post-traumatic stress disorder. One of them is pharmacological. So we tend to use medications such as antidepressants. And there are two that are actually commonly used, and these are Paxil and Zoloft. The other aspect is we use cognitive behavioral therapy. And why we use cognitive behavioral therapy is we try to refocus the stress that they might experience related to the particular precipitants. So we might use it basically in desensitizing individuals in terms of going back within the hospital care system. So if someone had been working in the emergency department, we would gradually start bringing them back towards the hospital system, getting to the doors of the hospital, going into the emergency department. Those are the things that we can actually do for PTSD. There is a fairly good success rate with individuals, but about 15 to 25% of people continue to have PTSD for years.
Dr. Stiver, what strikes me is the fact that as horrific as the SARS experience was for the city of Toronto, at the same time, what we see in terms of, again, hypotheticals, are incidents perhaps on a much grander scale, which would have a ripple effect down through the healthcare community. I don't want you to engage necessarily in fictional projections here, but given the fact that you've done this research on, a fairly limited pool, what do you think needs to be done in order to make sure that this much larger type of, collapse of the healthcare support infrastructure, that is, the healthcare workers themselves, what needs to be done to prevent that from happening, given the fact that we might see an incident that stretches out not over a period of weeks, but, 2-3 months or more?
Mm-hmm. Well, in actual fact, our SARS continued on for a fairly lengthy time period. It started in March, it continued on to April. We had a second outbreak in May, and things really came back to normal probably by the end of June. So our healthcare workers actually had to deal with this for a fairly lengthy time period. I think what we found is that people actually rise up to the task. We know that we label many of our healthcare workers heroes, and many of them basically said, I stepped forward and I did what I really needed to do. I think that addressing the fact that these people actually went out on a limb and did what we expect them as society to do, but we also need to recognize that they need some assistance in doing this kind of work. I think that they need to realize that there is recognition for having done this work, and one of the things that has been a major factor is the fact that there was a lot of initial response to the healthcare workers' concerns. It dissipated very quickly when the system started to feel like it was being overwhelmed. So healthcare workers want to know that when they need the resources, when we needed N95 masks, they want the healthcare system there to provide that for them. What they also wanted was for further education in terms of the general public, and the general public to understand that these people were not basically going to be the carriers of this disease into the community. So they found it very difficult that when they tried to access services themselves, such as dental services, when the dentist found out that they were actually a healthcare worker, the dentist said, listen, we'll see you in 3 to 4 months from now when all of this has passed. When they went to dry cleaning, people had their dry cleaning refused because they knew they were a nurse or a physician working in a healthcare facility. So I think there's a lot of work that needs to be done in educating the public and providing resources for healthcare workers to feel like they will be safe and comfortable in the environment that they're working in.
But in terms of educating the public, as you pointed out a moment ago, you indicated that most of the people surveyed said 9% got information from the public health sector, and that the vast majority relied on, information they picked up in their workplace or TV, that is the media. And do you see a greater need to emphasize a proactive public health role in communications, including, going so far as to seizing, some access airwave to the general public in the event of some larger scale event, as opposed to leaving it up to the media to filter the information? Or what would you...
Yes, I think people really wanted credible sources of information. And what we actually had was we had a number of individuals who on a daily basis provided information. And we knew in Toronto that at 3 o'clock on a daily basis we would have a public health briefing. And everyone tuned into the public health briefing. By far what we found was television is the most powerful source of information. We thought people were going to be turning to the new technologies, that they would be surfing the web, that they would be looking on the internet. That was actually not the case. What they were actually doing is they wanted to see somebody who was actually speaking to them in a medium that was easily accessible, and that was the television. And I think the concept of having a public health channel that would provide information on an ongoing 24-hour basis for individuals during a crisis like this would be absolutely wonderful. Because I think what we also found was that media sometimes tends to sensationalize some of the aspects of these outbreaks.
Well, Dr. Styra, I want to thank you. I must say that you're addressing, non-psychiatrists and, non-mental health care worker types out here in this audience. I wish we could perhaps tap into your more clinical expertise, but again, we appreciate you being here this morning very much. Thank you.
Thank you very much for having given me the opportunity to speak with you. Thank you.
Having looked now at one dimension of the crisis in Toronto, we're going to take a different tack. Our next presenter, Jacqueline Scott, is a senior attorney with the Center for Sustainable Health Outreach. This is part of the Harrison Institute for Public Law at the Georgetown University Law Center. It is also, and she'll correct me if I'm wrong, I'm sure, it also involves the University of Southern Mississippi. It's a joint project. But as we talk now about, what we're doing, that is interoperability, multi-agency responsiveness, multi-agency decision-making, not just, again, the technologies that enable real-time communications, shaping the direction that response is going in, but in this instance, talking about those population sectors that are the most difficult to access. And I think, if you recall, I mentioned that I had been working on how do we best alert and warn the deaf and hard of hearing here in Maine earlier. And you get into that type of work activity and you suddenly realize how challenging it can be. So this Scott is going to talk specifically about this whole issue, bringing healthcare, bioterrorism response as it impacts on vulnerable populations. And without any further ado, Jacqueline Scott, we welcome you this morning.
Thank you very much. And you have to bear with me. I'm used to being right there with you. So this is my first time using this kind of technology. So if you can't hear me or something's not correct, just shout out and I'll try to redirect myself. And I think my slides are there. Is that right?
Yeah, that's correct.
Yes.
Okay, so I'll just say next here and there, and we can move through it. We can move to the first slide now. And what I'm going to hope to do today is to really put a framework around what's happening currently in the public health system and how we could effectively integrate vulnerable populations into emergency response teams. This quote was back in 2002, and it really focuses on smallpox and other attacks here on the United States populations and the importance of us being ready, and how at that point in time we really were not ready despite how much effort and energy folks were putting into making plans and ramping up. We've made some progress now, and as you've heard, many states and many cities have done wonderful things. And so what we are hoping to do now is to make the point that as we focus on the bricks and mortar, as we focus on making the plans to get to communities and cities and states across the country, that we need to make sure that we keep vulnerable populations in mind. So to make the point more clear, it's just to say that, social inequity affects all aspects of public health currently, and bioterrorism preparedness is no exception. Whether or not we leave some people behind as we plan for how to respond to a bioterrorist attack really depends on our willingness to closely examine the ways in which a one-size-fits-all approach to planning may not sufficiently protect groups of people who tend to fall through the cracks of our public health system. Next slide. For the purposes of this presentation, vulnerable populations are those groups who, because they are already experiencing greater difficulties in accessing health under the current and normal system and in normal circumstances, they will undoubtedly face disproportionate vulnerability to illness and death in the event of a bioterrorist attack. These are people that we are looking at, the elderly, children, the disabled, the uninsured, the underinsured, those who don't regularly have access to doctors. In addition, we know that if a person, no matter what their status, as we currently heard about the healthcare workers attempting to access the system, no matter what their status, if they are infected as a result of a bioterror attack and it goes undiagnosed, there is a great likelihood that they will infect others. It's just result and consequence. So when we're looking at people who are unfortunately many times unemployed or day laborers and come in and out of communities and then go into places where they are, for all intents and purposes, either very isolated or disproportionately kind of disenfranchised from greater systems, then we can really tie the correlation to this population moving in and out of their natural arena and back into the everyday lives that touch us all on buses and cabs and subways. So what affects this population affects all of us. The definition of vulnerable here relies on the premise that current barriers between this population and the nation's health system will affect the ability to obtain necessary information and care during a bioterrorist attack. Indications of vulnerability include geographic and cultural barriers, poverty, lack of trust into the system, ethnic minority status, and speaking English as a second language or not at all. Next slide. So what do we already know? The data from the Institutes of Medicine and others tell us that ethnic minorities consistently receive less health care and less quality health care when they do access the system. Controlling for other contributing risk factors, blacks and Hispanics are less likely to regularly see a physician, less likely to obtain preventative care, and less likely to enjoy equal care once they are in the healthcare system. In addition to these barriers to health care, many ethnic minorities do not speak English as a first language and therefore face daunting communication barriers to accessing care. Unless the public health system takes steps to close these gaps, these same barriers will impact the emergency preparedness system and plans that are currently in place. During a public health crisis, these barriers have potential to significantly impact the level of human suffering that people will experience. In particular, the health system's resources can be very stretched, as we've seen from the experience of September 11th. And they're stretched enormously thin in an emergency of that proportion. And normally vulnerable populations and groups are at risk of being left out. For example, dense urban areas with few doctors will find themselves in desperate need of more qualified health professionals to come in to help them if an infectious disease outbreak occurs. Not only will certain diseases spread more and spread more rapidly in dense populations, but also existing health resources may be insufficient to handle the demand. Additionally, cultural and language barriers make communication of vital health information difficult, and sometimes, if not impossible even, to overcome. So how do we do this? Failed communication of bioterrorism management instructions, such as adherence to quarantine or medication schedules and protocols, could mean the difference between life and death. An example is that, not even in a bioterrorist emergency, but in preparation for any emergency, we are looking at coastal areas that are hit hard by hurricanes. We're looking at Tornado Alley. We just spoke about, Indianapolis and Indiana and the difficulty with tornadoes. Well, in a very coastal region of North Carolina, in a small community a couple of years ago, about 2 years ago now, there was a huge hurricane warning. There's a small population that's now really growing of non-English speakers that have settled into a couple of particular counties in the coastal region. And the experience that folks tell us there has just been very frightening, in that as the communication alerts go out and the TV and the radios are sending out messages, these populations of non-English speakers often are left out of the message until very, very late in the game. And since many are day laborers and go out into various areas outside of their home counties and home areas, they found that during this one emergency, when they came back home to go to their grocery stores for daily stops, the shelves were empty. There was a sheer panic as to what really was taking place. There was no water. The basic necessities were not there. And it wasn't until they found that this community had to come back together to themselves to try to figure out who could understand what was happening, and to reach out to their local dioceses and other parishes there in this community to explain to them what was happening, and to then call for extra supplies for these families, they really would not have been covered. And so this is an example of everyday life, not even a bioterrorist attack or biosecurity emergency. The public health system must specifically account for the special needs of vulnerable populations and communities, and how bioterrorism emergencies will really amplify these needs becomes clear when we use natural emergencies as an example. Next slide. So what does this mean? What do we need to do? What are some of the solutions? Well, I think that we really need, and we're starting to see this across the country, dynamic, unique partnerships among public and private institutions, community organizations, faith-based organizations, and the business community coming together to help ensure that the country's most vulnerable populations are protected in the event of any emergency. Within these partnerships, though, we really need to develop a response to specifically incorporate what we characterize here at the university as a community-based community health worker into these state bioterrorism management teams. These and all of the plans that are being created. We need to incorporate this level of worker at the community level into these systems to offset the disproportionate risk of bioterrorism events posing absolute devastation in some ways and isolation on vulnerable communities. Next slide. Why do I suggest community health workers? And I will refer to them probably throughout this as CHWs for short. Why are they a specific community response to this need? The concept of community health workers is not new. Community health workers have played a vital role in the healthcare delivery system in this country for many, many years, and are very active overseas in the international arena. The term is used here in this country nationally to describe and to unify outreach educators, health advisors, and health promoters. They are often really the vital tipping point people in their communities, the trusted peers and members of communities who daily promote healthy living by educating about disease and injury prevention, intervention, treatment, and whose assistance within the community to its members really help them better understand and access health and human service systems. Next slide. CHWs are also critical in minority and immigrant and rural communities, where services provided by physicians, nurses, and clinical facilities may be limited, or where access to and understanding of those systems may also be limited. They have a greater likelihood of facilitating communication directly with patients and members of their communities, and are more sensitive often to the cultural issues that specific communities are facing. In many communities, CHWs are the gateway to care and consistent links to services. As sectors of the medical community and public health community continue to mobilize and come together around building the awareness around preparedness for emergencies, low-income families and vulnerable populations living in rural and urban areas have to be fully integrated into any new emergency response system. Persons living in inner cities and very rural regions of the country are often, as I said, economically and socially disenfranchised. And as a result, they are often difficult to locate and to serve on a daily basis. And therefore, they often receive very little quality health care. However, CHWs are in these communities already, making links and reaching these groups in a myriad of ways, attempting to close existing gaps. However, I do recognize that this group of workers, this group of grassroots workers, don't necessarily have the high-level medical-related expertise that some may say they need. But we're not talking about diagnosis or treatment. We're not talking about specialties. We're talking about their knowledge of communities, their ability to effectively communicate with members within these communities, and their innate advocacy skills that make them really a valuable resource for community-based leadership in bioterrorism preparedness, and really important members of existing multidisciplinary teams. So how might this work? What is the vision? How do we think that this will link? I'd like to take a moment to try to put all of this in perspective and look at specific examples. Here at the Harrison Institute, we've been taking a look at the plans that the states have been putting together around preparedness, and we've conducted a mini assessment on how these plans actually anticipate providing and reaching the vulnerable populations and caring for these folks in their communities. So for discussion purposes at this point, I'd like to use Michigan as a case study. As a backdrop, most of you know, the Federal Department of Health and Human Services is the umbrella organization for numerous agencies and offices. But relevant to my discussion in this example, I'm going to just focus on the Centers for Disease Control, the CDC, since it's the nation's expert, in disease control and prevention. In order to receive federal funding for bioterrorism preparedness, states had to complete plans which were to look at how they would cover their state in the time of an emergency. Each agency had specific requirements, and so CDC had a number of requirements that it set forth. Next slide. The CDC set out 14 critical capacities organized within 6 or 7 topic areas that had to be met in order for state plans to receive continued funding. The topic areas were bioterrorism planning and readiness assessment, surveillance and epidemiology capacity, laboratory capacity, next slide, information technology, health alert network communications, risk communications, and health information dissemination, and education and training. Taking the critical capacities alone listed here highlight the need for a robust networking of partnerships between various levels of government and health personnel at the state and local levels. Note, though, that these capacities are really just the minimum requirements for the bioterrorism planning. I am not going to go into depth about all of the requirements in the interest of time. But providing this as a backdrop, let's take a quick look at a couple of the pieces of Michigan's plan. Next slide. Michigan's bioterrorism plan was created by the Michigan Department of Community Health, MDCH. This was to be their guide, Michigan's guide for bioterrorism response. MDCH was given the responsibility to develop a bioterrorism response plan by the Michigan Emergency Management Planning Agency. The plan background acknowledged the central importance of building a strong public health network for effective bioterrorism response. This in itself is precisely the promise of CHW, community health worker, involvement. Strengthening public health networks at a local level. Similarly, several of the responsibilities that the agency required from MDCH to have in its plan resonate with the skills of CHWs and their capacities. Next slide. The agency required a couple of things that I'd like to highlight. They required coordinating and investigating controls of communicable diseases, issuing health advisories and protective action guidelines to the public, coordinating a mental health needs assessment and crisis counseling, and having liaisons to serve between federal emergency health and medical programs and services and those at the state and local and community levels. Each of these at a fundamental level within the Michigan plan and within the state agency in Michigan, all of those things at a fundamental level are really closely aligned with what CHWs have to offer. So there was a good match in accomplishing some real grassroots outreach to cover those that are most vulnerable. Next slide. But let's look at their communication and notifications provisions as an example, a specific example of a possible match. There were two main aspects of their communication and notification plan, and they were divided between categories of planning and, as you can imagine, response. CHWs can play an important role in both aspects. Within communication and notification and planning, CHWs would be well suited to participate in many of their planning requirements, disseminating bioterrorism-related materials to their communities, developing and disseminating and participating in education and training programs for health professionals, identifying a special population wherever it may be, whatever their needs are, and coming up with ways to effectively communicate with that population, exploring development of effective communication venues themselves, not just dependent solely, for example, we're talking about in our daily lives as we sit in our offices and we get our email alerts to certain things, or we get our phone calls on our cell phones and our pagers and things like that. Well, many of these communities are, if they're very rural communities, they are not wired to receive these kinds of outlets. We have various organizations and foundations, like the Gates Foundation, for example, that have really taken on very rural communities to try to get them wired to receive this information. But then you turn to even a city like here in Washington, D.C. Many of the public school libraries, unfortunately, are very underprepared in terms of just the use of technology and the use of computers for district residents themselves. So we don't have pockets and places set up to use that kind of technology. But when you look at someone utilizing the resources of someone who knows the community, they could come up with or assist these emergency management teams in their planning on how best to communicate with them. The plan for MDCH to develop the plans also were for MDCH to develop and distribute the materials that describe infectious agents and infectious diseases and symptoms, and to provide recommendations for how to deal with those diseases. How do you prevent morbidity and mortality? CHWs could help in the distribution of that information. And that's only to the extent that we are informing and educating, not giving medical advice. They could also distribute materials to community members and have discussions around and with community members about how to minimize the risk or exposure to certain elements. The plan also calls for the development of what they term an emergency notification network, the effective network for communicating the information to states, counties, localities, and communities. To be effective, community health workers really should be a part of this network. At the time that we reviewed this plan, though, the only folks that were included in this network, the original local partners, were, as you can imagine, the local public health department, local emergency management, law enforcement, hospitals, and clinical laboratories. They did not include the community-based workers. Additionally, there was no requirement for all of the partners to be notified in all emergencies. There were various protocols for notification under the circumstances and depending upon what the emergency was. So, we really look at numerous ways that we really can communicate with and more effectively with local grassroots communities through the use of this worker. Communication and notification requirements of the plan also include developing education and training programs for healthcare professionals and clinical laboratory personnel. CHWs are invaluable in this instance in that they can assist and collaborate in developing culturally appropriate and culturally sensitive modules for programs for other professionals to be able to implement, to also help professionals and emergency responders respond more effectively and interact with these communities in a culturally diverse and culturally appropriate manner. Finally, identifying special populations and specifying means of communications within them is another aspect of the plan's requirements. The Michigan plan specifically identifies that their potential special needs populations are non-English speaking residents, military personnel, students, intertribal councils, the elderly, homeless populations and homeless shelters, non-readers and individuals with low reading levels, and assisted living centers, along with a group of migrant workers that they have there in their state. And these are precisely the realms at which we say that this level of community outreach worker could be helpful. They could identify special populations and work locally with teams of providers to strategize and implement how to be effective and how to communicate emergency policies and procedures to these special needs groups. Well, what does all this look like? Next slide. What we've come up with is a couple of draft diagrams. We've taken the CDC interim recommended notification procedures in the event of bioterrorism attacks and incorporated communications with CHWs. And we presume that there are a number of different levels that it could happen. If a local health officer, for example, is informed somehow of a bioterrorism emergency, or the local health officer suspects that they have a bioterrorism outbreak or some sort of gas release or something, and there needs to be some confirmation on the ground. As they communicate with the emergency response teams, there's a linkage there with the community health worker or a cadre of outreach workers within that territory, within that region, within that census tract, wherever it occurs, to allow some on-the-ground management and notification of residents. And also validation and feedback to what they are questioning in terms of getting the factual basis back to those with the medical knowledge to make the right call, to know who to notify. But at least the communication on the grassroots level is there. On the other side, there are pre-established notification lists that exist in these plans, and we think that there must be a level of trained grassroots worker who is a part of that notification list, so that we can get information into communities that that does not cause panic, that does not sheerly create people's hysteria, but again educates and is able to be a first response on a level of trust that exists there in the community. Next slide. How do we presume that some of this can take place and some of this happen? Well, we know, and we've talked a little bit about this morning, about the importance of training and riding the balance of overtraining, but having some core training done. We've looked at training curricula out there. The CDC has training curricula, and other national and federal organizations and states have developed training curricula. And we think that if you take this core of people and integrate them into those teams that are already receiving this training, you broaden the level of expertise and you broaden your ability to respond at a community level to these incidents. Now, let's look at the community health worker's specific role in the public health department. We've talked about disseminating information. Let's look at the surveillance opportunities. I often use West Nile virus and the instances in Baltimore that took place early on. There was an elderly gentleman a couple of years ago who died of West Nile virus. And he went for a number of days not being seen or heard from in his community when he first became ill. Had we had a grassroots or community response, someone in the community that sort of knew him and knew that, well, I hadn't seen, and I don't know the gentleman's name at this point, and that's not relevant, but Miss Brown, who is the neighborhood communicator, could have checked on him. Or perhaps we have community linkages where we are getting the word out to these communities that say, if you have standing water. And all these things are now taking place in the communities in Baltimore and other regions across the country, but it has taken time to ramp up just in a natural response, not even an emergency bioterroristic attack, but in natural responses. So we need to build a greater link to the communities. They also can serve in existing volunteer corps. And we're going to, I think on the agenda later on today, talk a little bit about volunteer corps. So we're not talking about creating additional systems. We're talking about integrating core personnel into existing systems. The same with health providers, the role of CHWs with health providers. Healthcare providers need translators. They need credibility in some of these communities, because very honestly, they don't have trust. And also in very rural communities, they don't have the linkages and the contacts. We don't have as many critical care hospitals as we used to. There's 60 miles between one hospital where one community is and the nearest hospital in some very rural regions of, for example, Mississippi, Alabama, Louisiana, within the Delta. We also can utilize this worker to collect vital information and to disseminate information. And what's their role with the community? Let's talk about if we do need to immunize people. How do we take the fear out of and allow the trust to come in? How do we talk about preparation for things like hurricanes and tornadoes or earthquakes on the West Coast? Things like that. Very basic responses where we can get into the community and get the trusted information there. Well, in the interest of time, I want to wrap up. In case there are questions, there are many more items that I could highlight in the Michigan plan, or many more examples I could give to you from this perspective in terms of creating a link with vulnerable populations. But as we move to the very end, the next steps and the benefits of CHWs, I just would ask you to just take a quick look at the next couple of slides that are there with you to give you some ideas about these benefits that they could offer to you. And just understand that it is important to have and utilize this grassroots worker in the responses that we create as we move forward. The very last slide is next steps into action. I think, again, I'll reiterate that we just need to integrate these vulnerable populations and their special needs into the plans, provide a framework for them in the public health departments, to really develop rapid responses to vulnerable communities, recruit and train a cadre of workers that really already exist out there in these communities and are working daily for health departments and hospitals and health clinics, and also develop culturally sensitive and culturally appropriate training materials for responders to help them feel more comfortable in accessing and communicating within these communities, to help them feel better prepared to do their jobs. So I'll stop there, and I thank you very much for this opportunity and am available for questions.
Well, thank you, Ms. Scott. I think everyone can now better understand why she served in an advisory capacity to the Governor of Maryland. She certainly has done a very good job here in bringing us this very important dimension of the interoperability puzzle. In other words, if we have a map on the wall and you cannot penetrate in to designated areas on the map, designated zones, population centers, because you lack the human resources that are skilled and knowledgeable of that population, then you don't achieve interoperability. When we talk interoperability, we talk, the full level of response. And my first question to you, Ms. Scott, is with the community healthcare worker, as you have described it here, there is no central organization or association or registry of those healthcare workers now. Would that facilitate the overall incorporation of the CHWs into a more responsive national organization capability?
Actually, yes, it would. And what's happening now is that we are working nationally throughout the states to help community health workers organize themselves, define who they are and what they're doing. And there are a number of states that have received funding, private organizations that have taken an interest in making sure that we can locate who these workers are, who is employing these workers, what kinds of training these workers have. Many of them are grant funded or funded to really work in specific health indices. So, for example, a health department may have them spread between their, prenatal care, their outreach programs related to HIV and AIDS or hypertension studies, things like that. So we do need to bring them together, but they exist in every state. And are working many times linking now with faith-based organizations that are now branching out to do a health outreach in the greater sense of holistic health and treatment.
But you're right. Later on today, we will talk about Citizen Corps. And we do have the CERT out there, the Community Emergency Response Team. We have the DMAT out there. We have all of these different levels under the NMDS, for example. And I find it not particularly comforting that we haven't been able to formally address this issue of bringing this very important group of healthcare workers into the system. Are you optimistic that things are going in the right direction now?
Well, I'm optimistic. I just think there are a couple of things that have gone on. We have talked with various levels of people in the federal government, in Homeland Security, and in HHS, and we've talked at the very local level to states and counties about this issue, and all recognize that it really is important. I think the issue goes back to, the very first presenter talked about some of the burdens that people are having in trying to balance the resources and the time and the critical nature that states, the decisions that states are having to make between where do I put the energy and funding. If I need more fire trucks and I need to train my emergency personnel, I've got to do that first. I recognize these other things are gaps. And that's where we come in. We try to offer them both technical assistance, but also the ability to kind of see where they already have the framework. And then they already have this cadre of workers there, and that it's not so hard and overwhelming to make the
Ms. Scott, stand by if you can hear us. We cannot hear you. You have just lost your feed into UMaine only within the last 45 seconds or so.
a lot of different areas.
So, George has a question, Ms. Scott.
Hi. To what extent can some of these activities be performed by volunteers? Because there's a lot being said about the resources being stretched thin. I mean, some of the maybe communication. I mean, is that something that we should do more with? Like I see crossing guards. Lots of schools have crossing guards, and I think those are volunteers. It seems to me there'd be a lot of people who want to get involved, even in terms of just being a neighborhood kind of community communication service.
Well, I agree. And actually, a lot of this work is being done volunteer in most of the rural states. There are volunteer programs out there, even dealing with diabetes prevention and breast and cervical cancer, all kinds of health indices. These groups of people go through volunteer training and are out there in the community because, very honestly, the money is not there to provide for them full-time job opportunities. What we are suggesting is that there is room for both. Where the funding exists, we think that there is a prime opportunity to develop a significant workforce that can link here to help close other barriers in healthcare while helping in this arena. But on the other end, to the extent where there are volunteers and where we have core curricula and standards of practice for these volunteers to be able to do their jobs, then I think we should utilize them. We also created a mini model of sort of a reserve corps, that you have a core group of people who are trained for times of emergencies like this. And so when they're while they may be doing their daily CHW outreach activities, when their emergency duties kick in, then perhaps we have an allocation of stipend or something to support their efforts around that time, much like we do in a Army Reserve Corps or other times, where we pay them for that level or that intense training or that time that they have to be called to serve in this capacity.
Okay, thank you.
Well, thank you, Ms. Scott. I just want to remind everyone that if you'd like more information about the center, and please correct me if I'm wrong, but the website is www.csho.org. And
yes, and as a matter of fact, you can also link to us. You were right in the beginning. We were originally established as a joint partnership between Georgetown and the University of Southern Mississippi, because we were focusing on helping bring capacity to the rural regions and particularly the Delta regions of the country. So you also can, if you get on the Georgetown University Law Center website, you can also link to the Harrison Institute and find us there, because the Harrison Institute is the umbrella for the health program here that I teach out of. So there's a link also there to us.
well, again, thank you very much, Ms. Scott, for joining us this morning.
Thank
We appreciate
you.
your time and input.
It is my pleasure, and I look forward to the afternoon's presentations.
We're now going to take a break for lunch, everyone. We'll convene back here at 1 o'clock, and we'll get right into the CDC Public Health Information